All right, so I thought I would talk about clinical pearls and cerebrovascular disease. Uh, so what I think like to do is go over some cases that are interesting and some clinical situations that can occur occasionally. So why don't we get started? All right. So first of all, I have no disclosures. Nothing interesting to talk about. Next slide. So case number one, a 57-year-old right-handed man who has atrial fibrillation comes to the emergency room after the 4.5 hour window, so he's not going to be a TPA candidate. The on-call neurologist is alerted for the evaluation of possible stroke, and the report that you get is the following. So he's sleepy but arousable. He has a global aphasia. There's no forced gaze deviation. There's a dense right visual neglect and field loss, right hemiparesis, right sensory loss, extinction to double simultaneous stimulation. There's increased tone and reflexes, and there's a right upgoing toe. The CT shows an ill-defined left-sided lesion. The diagnosis that he's given is a left middle cerebral artery stroke, probably fairly large, and he's admitted for intensive monitoring. So 12 hours later in the ICU, he became subtunded with bilaterally unresponsive pupils and spastic quadriplegia. The follow-up head CT shows the following. So what we see here is a stroke, but it's not within the middle cerebral artery territory. What you can see is it's within the posterior cerebral artery territory. Now, you might say that that's a little unusual, and what's going on. You gave me the history of a left MCA stroke, and now you're showing me a PCA stroke. What's the deal? So what's interesting is good, famous people have been snookered by PCA strokes presenting uh, just like middle cerebral artery strokes. So in order to sort of get this, let's go over a little bit of the anatomy. So what we have here in the first portion of the slide here is the top of the posterior cerebral artery. The first branch of the posterior cerebral artery goes to the midbrain. The second branch goes to the thalamus. The third branch goes to the temporal lobe. And then there are two branches that go to the medial and lateral occipital lobe. So what happens is a really large PCA stroke will give sort of a larger infarct of the entire territory, where smaller strokes, either distal strokes, will just give you occipital strokes, and maybe they'll just give you a thalamic stroke, right? So here's an example of this. This is just a thalamic stroke, right? So probably there's just an occlusion in this one of this artery here. Here's a big occipital stroke with some midbrain involvement, so you're probably, and some thalamus, so you're probably talking about this branch, that branch, the P1, P2, and maybe a little bit less or not at all of the P3. In this case, there's just a thalamic stroke, so maybe it's just a little ding right of the P2 here. So it's important to remember that the PCA does more than just the occipital lobe. Really, the entire PCA, the P1 through 4, feed the midbrain, thalamus, temporal lobe, and occipital lobes, and there's a medial and lateral occipital lobe. So what's interesting is that depending on what portion of the PCA is occluded, you can have different type of syndromes. So there's basically, we're going to talk a little bit about proximal posterior cerebral artery strokes and superficial posterior cerebral artery strokes. A proximal posterior cerebral artery stroke localization is defined as involving the midbrain, the thalamus, and posterior limb of the internal capsule, that proximal end. The superficial posterior cerebral artery is defined as involving anterior and posterior temporal lobe, callicrine fissure, and the parietal occipital arteries. So the proximal portion, I'm going to go back one, the proximal portion ends up being midbrain and thalamus, and the more distal portions end up being more temporal lobe and occipital lobe. We're just going to go forward one more time. All right, and what you find is that often patients who have the proximal posterior cerebral artery stroke will have a severe motor deficit. They can have asterixis because of thalamic involvement. They can be a palmomental sign, but they don't get visispatial neglects or aphasias or neglects. While the superficial posterior cerebral artery strokes will sometimes have a severe motor deficits, but will often have visual spatial neglects. They'll often have aphasia that is probably temporal lobe or thalamic in origin. They can have visual spatial neglects, right? So what can happen is that a lot of these symptoms we associate with middle cerebral artery. But don't forget that a posterior cerebral artery infarct, especially if it involves enough of the branches of the PCA, can present not only with neglect and aphasia, as well as severe motor deficits that look just like a middle cerebral artery. So the clinical pearl is dominant MCA stroke is fairly straightforward to diagnose clinically. PCA strokes, especially those that involve the dominant hemisphere, can resemble an MCA stroke in the acute setting, especially when the stroke involves the entire temporal and occipital lobe with some thalamic involvement. In this case, what happens is the patient developed a left PCA stroke and then closed off the basilar artery and had bilateral brainstem abnormalities. In general, patients who really have more than a field cut and neglect on examination when they have these big PCA strokes. All right, next case. So here's another one. So an 87-year-old right-handed woman with high blood pressure and diabetes presents with the acute onset of left-sided weakness. The ED tells you that she's weak, but is unable to elucidate whether there's a neglect present. So you ask, is the patient awake? And they say, yes, they're awake and there's no aphasia. Gee, thanks. That's not very helpful. When you ask them about the eyes, they say the eyes move around okay, I guess. When you ask about weakness, they say the left side's weak. Maybe she can't feel on that side. So the question is this a deep lacunar motor sensory stroke, or is this a cortical parietal stroke? And the difference between those is non-trivial, right? So one type of stroke is likely to swell. There's a hemorrhagic risk, especially over the short term, while a thalamic stroke may actually stutter, and you may think about using other interventions to prevent them from stuttering. One way that you can try to help sort these out, is this subcortical or is this cortical, is with something called the Eastchester clapping sign. So here is a patient, and I'm just going to activate this movie here. And you can hear me a little bit in the background, but what we're doing is we're asking the patient to clap. Let me see you clap, ma'am. Clap for me. Clap, clap, clap. Can you clap for me like you're at the theater?
I know.
Show me how you clap. Show me how you clap.
Well, some hurts, man.
Where's your arm? Where's your other arm? Show me your right arm. Show me your left arm. Can you show it to me? Where's your right arm? Show me your left arm. Ma'am? Show me your left arm. Show me your left. Can you point to it? Okay, so there's something called the Eastchester clapping sign. And the way it's done is you ask the patient to clap their hands. Patients who have a neglect, especially a parietal neglect, will often lift their right hand and they will begin to clap in the air in the midline. Patients without neglect will reach over and clap with the right on the dorsal aspect of the other hand. It's often associated with a nasty look from non-neglectful patients, as the patient will often think that they're being made fun of. But in general, patients with a neglect will clap the air when associated with a neglect. So what you can see is this patient here, and this is the patient after she got a little bit better. So you ask her to clap, and she holds a hand up, and she sort of claps the air a little bit. The next day, she's able to cross over, and she's able to identify the other side fairly nicely. So this is a quick and easy test for looking at neglects that can be useful. All right, case number 3. A 13-year-old boy presents with staring spells and transient leg weakness. He undergoes an EEG. During hyperventilation, he hyperventilates very well, and acutely during hyperventilation, he develops speech arrest and a dense right-sided hemiplegia. The EEG shows no seizure activity, but there's suppression of cortical activity. After a very long 20 minutes, the deficits resolve. So in this case, you wonder whether this is seizure or whether this is something else. So clinical pearl number 3. Children, in children, hyperventilation-induced TIAs or stroke is often secondary to vasodilatation or constriction. Specifically, this is a fairly sensitive and specific test for moya moya. It's felt in pediatric cerebrovascular disease clinic to be pathognomonic for the disorder, especially when it's not associated with any EEG abnormalities during hyperventilation. Moya moya is defined as a disorder of arterial occlusion and secondary collateral formation with small friable vessels. It looks like a puff of smoke on angiography and can be difficult to diagnose on MRI alone, but not impossible. And if we look at the next slide, what we can see is there are abnormal flow voids. So here's a T2 weighted image, and what you can see is there's sort of these funny little flow voids right along the proximal portions of the M1 middle cerebral arteries. You can see it a little bit better on the next slide here, where on the T1 you have all these little round lesions where there's basically the arterial system, and then when you give contrast, you can see all these little vessels. These are all the moya moya vessels that are enhancing with contrast, and you can see there's all of this collateral flow. So this is a fairly typical picture of moya moya just on MRI scan. That's not that if you do an MRA, you may pick up nicely, but you can see just on regular T1 weighted imaging. The moya moya on MRA can look like this. It can just have some abnormal vessels, and you really don't see the flow voids particularly well. So it can be a little difficult to diagnose moya moya just based on MRA because you basically just have abnormal vessels, but you don't really see those collaterals well. On the next slide, what you see is this is an angiogram, and what you see is the classic puff of smoke with all these little tiny collaterals coming off the middle cerebral artery in this case, and the posterior cerebral artery that is typical for moya moya, all these little friable collaterals. So in pediatric patients, when they hyperventilate, they can get vasoconstriction and they can get unresponsiveness. And you can see the little enhancing lesions within the basal ganglia on contrast MRI scan. Okay, so case number 4. I call this 3 pearls for the price of 1. So a 67-year-old man with multiple cardiac and stroke risk factors states he's doing well, basically until last night when he developed acute deafness, with resolution of his symptoms in about 60 minutes. He now comes to the emergency room with a new pure motor hemiparesis on the right that was present when he woke up. Approximately 24 hours later, he develops the acute alteration of mental status and is found to be shaking in all 4 extremities with a very fine clonic type activity. An EEG shows no seizure activity, but he lapses into a comatose state with bilateral unreactive pupils, dysconjugate gaze, quadriplegia, and has the following MRI scan. So what we can see here is this is a series of diffusion-weighted images. This is diffusion. These are perfusion-weighted images. This is the regular T2, and this is the MRA. So what we see on the diffusion is a little bright lesion here, and little bright lesions really within the pons on both sides. There's a little medial PCA stroke here that gets a little bit larger, and maybe there's a pontine stroke on the other side. So there's a little cerebellar, there's a little occipital lobe, there's bilateral pons. Nothing really much on the T2. When you look at the perfusion imaging, you see decreased flow within the cerebellum on the right. Basically, the ICA, the anterior inferior cerebellar arteries bilaterally, hypoperfusion of the pons and of the midbrain, and a little bit of the thalamus. And on MRA, there's basically a cutoff of the basilar artery right above the ICA. So the guy suffered an acute basilar occlusion. So Pearl 4A is, in a basilar artery occlusion, one of the prodromal symptoms can be hearing loss or tinnitus, and it can be so severe that nothing else is heard. It's probably, in these cases, due to occlusion of the anterior inferior cerebellar artery on one side or both sides, And so what you can see here is in this diagram, you have the basilar artery right here, and then off of it comes the anterior inferior cerebellar artery. This divides off into the internal auditory artery, which divides into the cochlear artery and the anterior vestibular artery. So an occlusion of the ICA can give you pure deafness, as well as vertigo because of interruption of blood flow to both the vestibular portion of the eighth cranial nerve as well as the cochlea. So you can get pure tone deafness with anterior inferior cerebellar artery strokes, which come right off the basilar artery. So the artery that feeds the vestibular artery as well as the cochlear artery feeds the middle ear. Infarction can be unilateral or bilateral depending on how much of the basilar artery is occluded. Okay, so acute hearing loss can occur in a prodrome to basilar artery occlusion, and this is a very nice paper from 1990 in stroke called Clinical Features of Proven Basilar Artery Occlusion. And what we can see, the most common are usually vertigo, headache, and neck ache, hemiparesis, but tinnitus and hearing loss is definitely up there. And that's usually because of occlusion of either unilateral or bilateral anterior inferior cerebellar artery strokes. And if you go back to the old school literature, this is a paper from 1946 looking at occlusion of the basilar artery, and it's a clinical pathologic study. And it's a great description. If you ever want to see really good descriptions of clinical syndromes, they used to do a really good job in the past is describing things. So 10 days before the entry of this patient, a woman with diabetes began having vertigo and tinnitus in both ears with a severe occipital headache and frequent crying spells. 3 days before entry, the headache and vertigo grew more severe. Her legs became so weak she could only walk with assistance. On that day of hospital admission, she awoke and found that the right arm and the right leg were completely paralyzed. Isn't that interesting? And we're going to talk about that in a second. During the hospital course, 4 or 5 days, there was some return of strength to the right arm. There was difficulty in swallowing. She needed a stomach tube. On the 8th day, she became unconscious. The left pupil dilated, and then both pupils were fixed and dilated. Breathing was rapid. Plantar reflexes were extensor on both sides, and death occurred on the 9th hospital day. So you can actually think about what happened to this person. So she had a basilar artery stenosis. It presented with headache and with vertigo, as well as deafness. And then what happens? This clot probably rose up the basilar artery, and she began infarcting the midbrain on one side and then the other, and then infarcted the entire midbrain. It's quite a terrible case, but not so unusual presentation of basilar artery occlusion. So Pearl 4B is something called the Herald hemiparesis of basilar artery occlusion. So people with basilar artery occlusions may present initially with a pure motor hemiparesis as the initial symptom of prodrome. It's actually not uncommon presentation and probably represents ischemia within the motor stacks of the midbrain. And what we can see in this very nice paper from 1990, where they talked about prodrome syndromes of basilar artery occlusion, a pure hemiparesis is really number 3 on the most common initial presentation of basilar artery occlusion. Pure motor hemiparesis, usually secondary to ischemia within the pons. And this is the first description of the Herald hemiparesis by C. Miller Fisher in 1988. And indeed, what he describes is in thrombosis of the basilar artery. It's not infrequent that hemiparesis is present at the early stage before there's progression to a locked-in state and before there are eye movement abnormalities. And so this is a nice paper, and I'll make sure to include this in the coursework. So next slide. The next Pearl 4C is the non-epileptic shaking in basilar artery occlusion. So convulsive activity in basilar artery occlusion has been described. It's probably similar to the concept of the hyperperfusion as in the limb shaking TIA. So limb shaking TIA is people who have large artery stenosis, usually carotid stenosis or MCA stenosis, and their TIAs are these limb shaking events on one side. Probably with basilar artery ischemia, there's the same type of limb shaking that occurs, but on both sides. There's often increased tone and posturing due to brainstem damage. And like I said, a very nice description by Alan Roper back in '88 of people with convulsive seizures or jerking in patients presenting with basilar artery occlusion. So the non-epileptic shaking of the basilar artery occlusion. Now I might suggest if we go back to this paper that this is not sort of one of the more common presenting symptoms, although I would wonder whether drop attack can be might have been caused by bilateral shaking that, of a non-epileptic type in these basilar artery occlusions. Okay, so case number 5. 43-year-old man with a history of smoking who suffered a hyperextension injury to the neck and head in a car accident, but really afterwards he was normal. He had no neurologic symptoms. In the emergency room, he did a CAT scan and it was normal. Several weeks later, he developed a partial Horner syndrome with significantly painful trigeminal neuralgia-like pain on the right side of his face. His, quote, Horner syndrome really just consisted of ptosis and meiosis without any anhidrosis, and there was significant trigeminal neuralgia involving V2. So next slide. So this is a fairly prototypic presentation of something called a Raeder syndrome, which is Pearl number 5. The Raeder syndrome and the Raeder's paratrigeminal syndrome usually occur with disruption of the ascending sympathetics along the carotid. So what we have here is the common carotid artery, right? And it divides into an external carotid. You can tell it's the external because it has branches. The internal has no branches until it reaches into the brain. And the internal. And what happens is these sympathetics divide along the external and internal. So the sympathetics to the face and to the forehead will climb along the external carotid, while the sympathetics to the eye will climb along the internal carotid. So if you have a dissection or damage to the internal carotid artery, what you'll do is you'll develop autonomic insufficiency just to the eye, but sparing the forehead. So a Raeder syndrome is a Horner's where you don't get anhidrosis of the forehead because the sympathetics along the external carotid artery are not affected. So patients with a Horner syndrome and trigeminal pain are often found to have occult dissection with pseudoaneurysm. And what happens is the pseudoaneurysms in these areas can disrupt the trigeminal nerve. So what happens is people will get a pseudoaneurysm, it'll disrupt these sympathetics, giving you a Horner's, and it will disrupt the trigeminal nerve, which has this really long nucleus all the way up and down, giving you a trigeminal neuralgia on the same side as the Horner's. And when you see that, you really want to worry a lot about carotid dissection and often with associated pseudoaneurysm. All right, so a Raeder's syndrome and Raeder's paratrigeminal syndrome from internal carotid artery dissection. All right, next case. An 84-year-old woman presents with acute onset of weakness from the left side of the face and left arm monoparesis, as well as some confusion. She has atrial fibrillation, but there are no carotid bruits. Given the atrial fibrillation, it was hypothesized that she had a small embolic stroke secondary to the atrial fibrillation. The MRI was done without MRA because they already knew that it was atrial fibrillation. And this is the MRI. So this is a diffusion-weighted scan, and here's the ADC. And what you see is these scattered diffusion bright lesions just within one hemisphere and not in the other hemisphere. And you can see that they're dark on ADC. So Pearl number 6 is something called the scattered pearls sign. So scattered DWI lesions within a single vascular distribution really are more likely to represent large artery stenosis, ICA or MCA stenosis, than cardioembolic or proximal source emboli. This finding is much more common than the string of pearl signs, which can be seen both with hypotension or with artery stenosis. In MRI patients with this pattern, MRA imaging of the head and neck is important to do if it's not already done, because this pattern often represents large artery stenosis. So this is a string of pearl sign where you have sort of diffusion bright lesions really within a single line, and they can actually absolutely can occur with large artery occlusions. When it's bilateral, you want to think about proximal, embolization or hypotension, but it tends to be less of a sensitive and specific sign than just one slide back, than the scattered pearls, all within one vascular distribution. All right, one forward, one more time. All right, so listen, those are my cases. So I'd like to thank Laura Jordan, who recommended the Moya Moya pearl and gave me some pictures, to Dr. Victor Arrutia, who recommended some cases, Dr. Steven Zeiler, who was a stroke fellow at the time, for suggestion of clinical pearls, Rebecca Gottesman, Christina Terzo, Robert Witek, and Lyle Ostro for being my co-authors on the Eastchester clapping sign and scattered pearl sign papers. All right, well, thank you very much.